We will go to the next question. This is regarding the next hot topic or controversial topic regarding immunomodulation. So how does immunomodulation influence the progression and treatment of sepsis? So, you can understand the mechanism contribute to the development of targeted therapies. Thus, this particular term and way of treatment is something which you can consider.
Yeah. So great question. And I think I want to kind of, don't want to be too negative about all the things that we're going to talk about. So immunomodulation, very simply put, essentially means that you're going to give a drug that changes the way the ongoing immune response is in that patient. So the basic way of thinking about it, which is what we have done thus far, is to say there is excess inflammation or there is excess immunosuppression. And you can manage excess inflammation with anti-inflammatory drugs and immunosuppression with immunostimulant drugs. What we don't say is the next sentence. So I'm going to rephrase that sentence. We can manage excess inflammation with anti-inflammatory drugs if the causal path to bad outcome is that excess inflammation. And I'm going to do the second thing, which is immunosuppression. We can treat immunosuppression with immunostimulator drugs if we know that the causal path to immunosuppression, to death, is immunosuppression. And I think the reason why I say that is twofold. I'm going to make two simple points. I'm just going to use the example of hyperinflammation and treatment with an anti-inflammatory drug. So if you were to give an anti-inflammatory drug to a patient with hyperinflammation, we know that patients respond to treatment differently. In other words, there is variation in treatment response. Some patients, when you give this treatment, based on systemic blood levels of excess inflammation, which is what we all look for, like CRP or IL-6 or whatever else that you think you want to believe is the reason for hyperinflammation, ferritin. You give a drug and your basic premise is that you're tackling hyperinflammation. But the other side of the coin is that patients could go on to die because they are now excessively immunosuppressed. We are never titrating anti-inflammatory drugs. We're just giving a fixed dose at one time point or two time points, and that's that. So they have a risk of immunosuppression. And often this is done on blood levels of a biomarker. Another reason why we haven't seen any success is to say you take a blood test and there is hyperinflammation in the blood. But at the same time, if you were to take an imaginary bronchoalveolar lavage sample and you look for the same biomarker, that biomarker may be very low. And by definition, if you say the biomarker is low and that is not hyperinflammation, the lung may be in a different immune state compared to the blood. In other words, the inflammation in sepsis has now become compartmentalized, and that compartments are different. So you then treat them with an anti-inflammatory drug based on the blood level of biomarker. What you essentially now have is a more immunosuppressed lung state, which causes a secondary infection. And therefore, you don't improve the outcome, you sometimes worsen the outcome. And we can make a similar argument for immunosuppression as well. So currently, we don't know enough about how best to immunomodulate patients with sepsis. So that's the first fundamental kind of building block to the discussion. The second building block to the discussion here is which of the inflammatory responses are bad for you. So if you were to take a panel of cytokines in a patient with sepsis, they may have raised IL-6, they may have raised IL-8, and they will have low HLA-DR, they will have raised IL-10. And if you were to pick and choose an inhibitor for one of these drugs, you will choose an IL-6 blocker because that is where most of the data is, or you will choose an immunostimulant like GM-CSF, which is where the HLA-DR suppression, immunosuppression due to HLA-DR expression is. And you give one or both of these drugs and essentially look for an improvement in outcome. And what you then have forgotten is that by blocking one pathway, you've essentially taken out another basic immunological concept, which is that immune responses don't happen in isolation. They are interlinked pathways. When you suppress one of the pathways, there is so much redundancies between pathways that something else gets activated and then causes the outcome that you wanted to prevent. So we are not yet at a stage where we can really understand how to precisely immunomodulate a sepsis patient. Then you come to the point, is there anything that actually makes any bit of difference? And I think the only bit of thing that I can probably think about, which is again slightly controversial, is the role of hydrocortisone, low dose hydrocortisone in the context of documented septic shock, with or without fludrocortisone. And hydrocortisone is a cheap drug. It is available everywhere. It is a fixed dose. The side effects are well understood at that dose in a critically ill patient, which is hyperglycemia, risk of secondary infection, bleeding. Those are the three broad risks. Those things are targetable, preventable, treatable. And it is cheap as chips, and that has been consistently shown to shorten the duration of needing for vasopressor therapy. The impact of mortality may be slightly more uncertain. So in a way, if you're a critical care doctor and you got somebody in front of you and they are in shock, and you want to give them an immunomodulator, the cheap and cheerful immunomodulator to give is 200 milligram hydrocortisone or equivalent doses over a 24-hour window up to 7 to 10 days. And the final point I want to say before I stop here is you can go down the depths of immunology and figure out much more complex way of looking at this. And one complex way of looking at it is to think about what are referred to in rheumatoid arthritis in particular, and other immune-mediated inflammatory diseases, what are referred to as signature cytokine concepts for the disease. So in rheumatoid arthritis, the signature cytokine is IL-6, and the second element of the rheumatoid arthritis paradigm is the use of high levels of efficacy with something like something much more broader than a single cytokine, like targeting a pathway, which is the JAK-STAT inhibition, which is Janus kinase pathway using baricitinib, where you are trying to block more than just one pathway. And I think in sepsis in particular, if you are looking for a signal based on basic science and Mendelian randomization studies, you would think about IL-6, where it has got probably the maximum value as an empiric thing to test. It is not to treat, it's to test. Hope I've answered the question that you're asking.
Perfectly. I think there's a balanced answer covering both aspects very clearly and with the definite recommendation. Thank you.